And at present, I must express my heartfelt gratitude to my teachers also, late Dr. Londe sir, for his teaching and guidance. He used to do many vaginal hysterectomies and in prolapse cases in Tarachand Hospital, Pune. Those days, sir used to do it is very meticulously and very in. And he was known for the fast surgeon, and is very fast surgeon. And he taught us the art and science behind the vaginal hysterectomy, basically. Uh, I'm I'm also attended the workshop of vaginal hysterectomy by Dr. Shirish Sheth uh, in 2010, 2010. Dr. Shirish sir said, sir from Mumbai, and he was conducting the vaginal hysterectomy workshop. After that, I have been very much this one enthusiastically is doing the difficult vaginal hysterectomies, and so motivated from that workshop also. I'm starting this topic because it's before starting this vaginal hysterectomy and the art of the vaginal hysterectomy, we should know the history of that also. In 18th century, Langens performed the first ever vaginal hysterectomy for uterine cancer, and first vaginal hysterectomy was performed by the Charles Clay in the 1843 by identifying the ligating the broad ligament vessel and other ligament. Opening of the 𝙪𝙪, cooling of the fundus, peritonization, anchoring of the stump of the sango, the vaginal wall, was performed by the Chauvet in 1880. In 19th century, vaginal hysterectomy was systematically studied and developed by the Professor Sims, Verdams, and Shorta, Keele, Bonis, and Mayo, which are from the Western countries. India also was not lagging behind in the contribution to the field of NDVH, vaginal hysterectomy. Stalwarts like the Dr. B.N. Purandare, Dr. V.N. Shirodkar, Dr. Mitra, Dr. Roy Chaudhary, Dr. V.N. Purandare contributed enormously in evolution of the vaginal hysterectomy. Dr. Shirish Sheth from KEM Hospital, Mumbai, made it popular as a NDVH in difficult cases also. The success of the NDVH depends on selection of the right operation for patient and right patient for the operation. NDVH is a relatively easy operation to perform. Movements of the finger, feel of the tissue, knowledge of anatomy, and surgeon's confidence is the secret of success. Mastering the art of the NDVH is an art itself. Abdominal hysterectomy is a surgery. Laparoscopic hysterectomy is a technological surgery. But the vaginal hysterectomy is an art surgery. That's why we should basically, when you come across the patients with hysterectomy, we think about hysterectomy. First thing, the vaginal hysterectomy, definitely. And for that, we must see about the indication and contraindications also for doing the vaginal hysterectomy. Before going to the other factors, you must uterine prolapse, because many of the vaginal hysterectomies are performed in prolapse cases. Before evolution of NDVH, the only prolapse cases and other cases are only done by the vaginal hysterectomy. The uterine prolapse can be described as a descent or herniations of the uterus into or beyond the vagina. Vaginal vault has three compartments. The anterior compartment consists of the anterior vaginal wall, middle compartment, that is the cervix, and posterior compartment. Basic knowledge of pelvic anatomy and the uterine supports is essential for the gynecologist in order to understand the mechanism of the prolapse and methods of correcting it. We should, before going to the learn about the vaginal hysterectomy, you should know the supports of the uterus. The first one, the active supports. The active supports are levator and muscles are active, and they are strong supports of the uterus, level 1 supports, that is called as. When needed, it contracts forcibly, but may get damaged with configuration or constant raise in intra-abdominal pressure. Second one, the passive support, endopelvic fascia and its condensations. Pelvic ligament, that is the uterosacral cardinal ligament complex, that is the complex uterosacral macandros. The pubocervical fascia and the rectovaginal septum, and their attachment to the pelvis and pelvic side wall to the arcus tendinous fascia of the pelvis, that is the level 1 and level 2 support. These three supports are very important before going to the surgical part. Under prolonged pressure and tensions, fascia will stretch during labor. That the fascia will get stretched and break, leading to the loss of support to the pelvic organ, and in turn result in vaginal prolapse. Peritoneal attachments that acts as a ligament also, which helps in supporting the uterus, that is the ovarian ligament and broad ligament. These are the list of indications and contraindications. We should say these are these indications, and that contraindication may turn into the later on indications also after the experience and that you get after doing the vaginal hysterectomy. That the indications are the mainly the uterovaginal prolapse, definitely. Second one, the AUB, abnormal uterine bleeding, fibroid up to the 12-week size, adenomyosis, fibroid polyps. These are the main indications for the vaginal. But after some years after doing the vaginal hysterectomy, you can master, you will get the mastery over the vaginal hysterectomy, and then your indications and confidence and expertise are increased. And then relative contraindications also turn into the indication, that is the uterus size above 12 weeks, benign adnexal pathology, that ovarian cyst, hydrosalpinx, and tumor masses and all these things, benign tumors, definitely. And sometimes the broad ligament fibroid also can be delivered and can be excised through vagina also. And then after the absolute contraindications are uterus size more than 20 weeks. That is absolute contraindication. Inaccessible cervix, cervical endometrial malignancy, except selected cases. That is means the first stage, and that one. Adnexal malignancy, it's already absolutely contraindication. Previous successful repair of UVF and all these things. Rectovaginal fistula, all already mentioned. It was mentioned that the narrow subpubic angle, nulliparity, and the previous surgery are the relative contraindications over the last decade. But these are no longer stands as a contraindication after evolution in vaginal art of the vaginal hysterectomy. The main these are the uterovaginal prolapse and abnormal uterine bleedings, these and fibroids, adenomyosis, submucous fibroid, fibroid polyps, and cervical fibroids also can be operated through vaginal hysterectomy. The scope of the indication grows with the growing skill of the surgeon, definitely. So it should be the aim of the surgery. It should be the restore the normal anatomy and maintain the or restore the normal visceral function and maintain or restore the normal sexual function also. The the associated condition in which the vaginal routes of hysterectomy has been evidenced to be safe and beneficial to the patient, that is hysterectomy in nulliparous woman. That can be done to vaginism because it's a difficult one. But in nulliparous woman also there is a physiological descent that is called as the tissue is firm, but still we can do the many times we can do the hysterectomy in nulliparous woman. You heard about that mentally retarded females that can be or that was operated with vaginal hysterectomy, I mean VH also. Previous abdominal pelvic surgeries, the dissection of the 𝙤𝙗𝙬𝙗 peritoneum and mobilization of the bladder may be the difficulty in some cases, but that can be done very easily with in previous abdominal pelvic surgeries also. That is the history of cesarean section. Prophylactic salpingo-oophorectomy, many cases can be done through this one. Hysterectomy in women with obesity. The obesity is the BMI greater than 30, 40. That is a moderate obesity and all these things, all this patient. The wound problem is when, in abdominal hysterectomy. And so the vaginal hysterectomy is beneficial in such cases. The relative contraindications that the uterus size greater than 12 weeks that can be operated with some years of practice. Benign adnexal pathology, ovarian endometrioma. Hysterectomy in cases of broad ligament, already told that. The sum of the heterological contraindications are truly indication to progress for the others. With experience, some of the contraindications regresses. The contraindication, that is also we have already seen these things. The possibility, types of the surgery and possibility of the vaginal hysterectomies and the previous sections, hysterectomy, hysterotomy or myomectomy, possible with extra care. Ventral suspension, that is a contraindicated, definitely. History of that abdominal slings and for prolapse, possible advanced level of scale, definitely not indicated. Operation performed on structure organs other than the genital tract, possible with cases in we can do the vaginal hysterectomy. Previous rectosigmoid resection or with low rectal anastomosis, we can do the vaginal hysterectomy with possible extra care. Are these the possibilities we have to just examine the patient and then we have to think how to go with this patient. Is the abdominal, laparoscopic or vaginal? But firstly, the vaginal hysterectomy is the no scar surgery, definitely, and there is through the natural orifice. That's why we must think definitely first in every cases of hysterectomy. So the root of the hysterectomy should be the first one. We think the vaginal hysterectomy. Afterwards we go into the preoperative assessment. Who will do that? The need careful and detailed preoperative assessment. Definitely, we must take the previous history, obstetric history, any medical history of any hypertension and diabetes and all these things. We have to rule out, and any thromboembolic diseases and all these things we have to search about that and valid consents and all things before going to the vaginal hysterectomy. We should take the valid consent of that. If we cannot do we stuck in the vaginal hysterectomy, we can go turn into the abdominal hysterectomy or laparoscopic hysterectomy. The preoperative counseling should be needed in such cases. Confirmation of the route of hysterectomy, that is very important before taking any consent. An objective of surgeon preoperative to confirm the route of hysterectomy, assess the fitness of surgery, include anesthesia and all this, to detect the anticipated complication and prepare to tackle them. Role of the ultrasonography, that is very important. The size of the uterus, that is mostly we must we must call definitely before going to vaginal hysterectomy we must take the good ultrasound of the patient that contains the volume of the uterus and the cervical length. That is very important to go for vaginal hysterectomy. Any adnexal masses, ovarian cysts, dermoid cysts, and all these things we have to rule out first before going to the vaginal hysterectomy. And previous abdominal or pelvic surgery, that is the myomectomy, cesarean sections, and all these things, hysterotomy. Examination under anesthesia, that's the most important thing before going to vaginal hysterectomy. Uterine volume, and that is already told that there's uterine volume in less than 100, because normally the volume of the uterus is 30 to 60 cubic centimeter, but equal to 100 and below the 100 is every gynecologist should do it through vaginal hysterectomy. That we must ask the sonologist to give the uterine volume of the uterus before going to the vaginal hysterectomy. 100 to 200 gynecologists should be able to do it with patients, definitely. About 200 to 400 is the best from gynecology with backup experience of above. It requires very much experience, definitely. And we should give the trial of VH, means vaginal hysterectomy. Keep available the LIVH and abdominal hysterectomy drum ready, and do that such a big volume uterus. These are the preoperative this selection means of the patient. You must see the size of the uterus, definitely. Mobility of the uterus by doing this PV examination. Intertuberous distance, that is a foraminal tuberous, is ischial tuberosity distance. This subpubic angle above 90 degree, that varies, but acute below 90 degrees subpubic angle, that may be difficult for vaginal hysterectomy. Digital examination of the means PV examination of the vagina. It is the 3-finger loose. Very much you can do easily the vaginal hysterectomy. Mobility of the vaginal mucosa, that is very important. Fornix depth of the fornix, that we have to see by doing the PV examination. Descent of the valsellum. Descent with the valsellum, that is you should catch the lip of the cervix and pull the with valsellum. If there is a degree of descent, then we must we can do the vaginal hysterectomy. Surgeon's experience, that is also countable in such a cases. History of previous surgery, that is also important. Then there is a score. If the score is 0 to 5, then very easy is vaginal hysterectomy. 6 to 10 easy. Difficult one, that is the 11 to 15 score is there, then there will be the difficulty in doing the vaginal hysterectomy. And very difficult is above 16. is the score to see the to manage the vaginal hysterectomy to how we go with this one. And these are UVA examination under anesthesia. The gold standard or bottom line for gynecologists should be every VH should be preceded by the EVA. Assess the uterine mobility, size, descent, and prolapse. Traction on the cervix with valsalem. That is the test which is very important before going to VH. The doctor shades cervicofundal sign. That is another very important sign. If you catch the cervix with valsalem and pull it, if it comes, if it is descended, and if there is a history of previous cesarean sections or any surgical history, then there will the scar of the lower abdomen will stretch down. There is the stretching of the scar with pulling the cervix with valsalem. That is the set cervicofundal sign. If it is positive, then there will be the contraindication because there must be the adhesion between the uterus and anterior abdominal wall. That is the ventrofixation of the uterus. That is called as the ventrofixation of the uterus. That is the most means difficult vaginal hysterectomy because there will be the multiple adhesions between the anterior abdominal wall and uterus. Adequate uterus-free pelvic space around the uterus. That is very important to go to the VH. Free vaginal mucosa around the both pouches. If you see the vagina with the sim speculum, if you see that posterior fornix is puckered and it's deranged and there is an irregularity in the posterior pouch, then there will be definitely the adhesions in the PO. So this is the sign that we must see that one also. If there is a free vaginal mucosa around the both pouches, anterior and posterior pouches. Normal cervical length of portio vaginalis with deep fornices. That is also important. That is the supravaginal length and infravaginal cervical length. Means and if there is cervical elongation is there, that is you must see that is also is there cervical elongation is the supravaginal or infravaginal. That you have to see. And then again the contraindication of VH. And the uterine volume. Again, the uterine volume is very important, 240 to 350 cubic centimeters. Restricted uterine mobility, that we have to already told that. Adnexal pathology, cervix flush with vagina, that may be the because of adhesions and all this thing. Inaccessible cervix, that positive cervicofundal sign, uterosacral adhesions with abdominal wall. So, preoperative preparations now. The surgical site infection, that we have to see there is a fungal infection, all that we have to treat before going to the vaginal hysterectomy. That the surgical site infection, we must see all these things. Bacterial vaginosis, that is also important. We must treat first before going to the VH. Antiseptic vaginal preparation before surgery, early first that one. And bowel preparation, we must give the before last night that one, the gas and dulcolax, you have to give that one before the next day of this one, VH. And that is bowel preparation with we can give the enema also if previous and next day you can plan for the VH. I preferably give the this one gas-X and Alcolax and at the night that enema, and we start the hysterectomy in the early mornings. And hemorrhage, if there is a profuse PV bleeding, that's AUB, and then we must see this. We must see that HB percentage and all that, and we must give the transfusion before going to the VH. Use of preoperative tranexamic acid. The injection tranexamic acid should give the before going to the vaginal hysterectomy. That is also very effective because the minor oozing and all this get stopped after giving this one. Semi-control should be see all these things. And preoperative antimicrobial therapy. I give the these injections, cephalosporin and group of antibiotic before 1 hour of vaginal hysterectomy. That is also very important. Prophylaxis for nausea, vomiting, and when the venous thromboprophylaxis is also means you must think if patient is severe obese and all, and any history of thromboembolic episodes, then you must think the LMWH in these cases also after vaginal hysterectomy. Ergonomics in the vaginal surgeries, that is also very important. The ergonomics is the concept of designing the working environment to fit the workers instead of forcing the workers to fit the working environment. Operation table height should be adjusted appropriately so that the primary surgeon and assistant may take proper position. Round stool with backrest has advantage for the primary surgeon and the operating surgeon. Knowing the proper function of each instrument, knowing the proper direction of retractions are important. Knowing the proper needle size, needle curve is very important. Even the needle holder curves and piercing the needle direction, anterior-posterior and posterior-anterior, are helpful in reducing forearm joint strains. Many times we piercing the needle if we are clamping and suturing the clamp that patient's right side. Then if you go pierce the needle from anterior to posteriorly, that will be the AZ. And for left side, if you posterior to anteriorly, then there will be the easiest way to suture the pedicle. The access to the 𝙤𝙖𝙢𝙤 and the recto-uterine pouches. Vaginal hysterectomy is a common operation in gynecological practice, generally for getting an access to anterior pouch, 𝙤𝙖𝙢𝙢 pouch, and recto-uterine peritoneum, posterior pouch, that possesses no problem, but needs zeal and confidence. That is important. Once this is acquired, half of the battle is won. Proficiency with the variety of the colpotomy techniques is essential for the effective performance of the vaginal surgeon. The step one for the this one important and access to the anterior pouch. Aqua dissection is very important. Infiltration of anterior vaginal mucosa. It creates the vascular tourniquet in the lower part of the uterus, and tissue planes are full with fluids, and it gives the proper plane of dissection. It acts as a vascular tourniquet also, and it gives the proper plane for dissection. That's why the aqua dissection is very important. Normally we use that normal saline 150 around 150 cc with 10 cc syringe and 10 number needle. Many of us use the adrenaline also. or some uses vasopressin also, but I think there is no need to give this one adrenaline vasopressin. Only plain normal saline is very useful for the aqua dissection. The transverse incision, now the first technique to open the to assess the anterior pouches. The transverse incision is made into the vaginal epithelium on the anterior aspect of the cervix at the level of the bladder creases. Join the anterior posterior incision by cutting the lateral vaginal wall, making the circumference incision. Sharp dissection on anterior vaginal wall is made with the scissor to cut the uterofascia, that is the cervico, cervico and fascia, that is the very important to this one, vesico cervical ligament, that is. Obtain the proper plane of cleavage between the bladder and cervix. That means the cut the vesico-vaginal fascia. And once the clean cervical surface is seen, the bladder retractor is put into the cervical surface and pressed firmly. With the bladder retractor also we can push the bladder upward and backward. That is also sufficient to push the bladder with the bladder retractor, and we'll get the plane of that one to open the anterior pouch. The bladder mobilized done, and we do not definitely we before going to the hysterectomy, we can go for the anterior pouch to open it. We just mobilize the bladder and dissection of the mobilization of bladder. We do that and go for the posterior pouch to open it. But we don't open the anterior pouch at immediately also, because it gets opened automatically after doing the second means second stump ligations. This is the bladder rugi and the level of the incision where the rugi starts. That is the plane of the that is, so you have to take the incision there also. The smooth cervical epithelium. There should be, we have to take the transverse incision, not the below that one. If you take the incision below that one, that level that means smooth below the cervical epithelium, below the smooth cervical epithelium, then there will be the problem. Will go through the cervix and there will be the bleeding starts because you will get the pit only. There no plane of dissection will get there. After doing the counter traction and traction and counter traction is very important because when we put the interior vaginal retractor to the that space, automatically the ureter goes away, and then you can apply the coccus to the uterocervical and McIndore's ligament. This but when we come across the vaginal hysterectomy with previous cesarean section patient, then the safer approach to be assess the this one vesico-uterine pouch is from the lateral part of the cervix. Because if the history is previous history is of cesarean section, then there will be the adhesions of the bladder. Bladder get adhesion to the cervix. Then there will be problem because when we go through the through and through bladder, bladder gets open. To get the in such a cases to get the anterior pouch, there will be you have to take the little bit precautions. That the safer approach to assess the vesico-uterine pouch is from the lateral part of the cervix. As in the lateral one, lateral one fifth, there is no addition because the central 3/5 is there is a definitely there is a adhesion between the bladder and the cervix. There is the attachment, but the lateral 1/3 from both sides is the free one. So bladder lies at distance, not directly on the uterocervical surface. Extra or more space between the bladder in cervix laterally than the space centrally. Namely, uterocervical broad ligament space. That was the space. This space is called as Dr. 𝙤𝙤𝙢𝙬 space. That was described by the Dr. 𝙤𝙤𝙢𝙬 in 1993. This anatomical space or surgical lateral window space with uterine size, average size is a 2 to 1.5 centimeter. It must be noted that space does not contain any uterine vessel. You just go to the lateral to the that bladder central adhesion and lateral window. You create that one with scissor. And you can just open the peritoneum there also, vesicular peritoneum, and the attached part of that bladder you can dissect with sharp dissection, and will get the plane between the cervix and bladder. This in this picture you must see that the who to go laterally to this Dr. Shed's lateral space, and it's a demarcated in this picture. Cervical elongation surgeon, you must see that also, so supravaginal elongation or infravaginal, supravaginal or infravaginal elongation. In supravaginal elongation, you have to take incision on that ruby also, not above that one. That as usual, but in infravaginal elongation, we have to take the transfer incision on vaginal wall. That's very upward to the up to the just below the urethra, because the infravaginal cervical elongation is there. That is that infravaginal elongation is present in the cervical, means prolapse cases, third degree prolapse and all this thing. In that case, in that patient, that you will get the infravaginal elongation. The step 1 you already described. And now the step 2, the access to the posterior cul-de-sac pouch of the Douglas. For opening of the pouch of the Douglas, you just catch the vagina with the long iliac forceps, stretch it, pull the posterior vaginal wall, and sharp cut with the scissor will open the posterior pouch and peritoneal cavities get opened. That is the blunt, sharp dissection with the scissor for the opening of the posterior pouch of the Douglas. Sharp cut you have to take. You can open that pouch of Douglas with intracervical access. If any difficulty, if there is a previous LSCS or some adhesions is there in posterior pouch of Douglas, then there will be, you can open that posterior pouches with the transcervical access to the cul-de-sac. And in this figure, we have shown that the access to the POD via posterior uterocervical broad ligament space. I have already mentioned that the anterior uterocervical broad ligament space, same the space is there in lateral space is that was the posterior uterocervical broad ligament space. You can get you can assess with this space, through this space the POD also. Step number 3, bladder mobilization. Anterovaginal wall is made with the scissor and cut uterus vesical fascia, and blunt blade of the retractor will draw away the bladder from the surgical field. That is the bladder mobilization. Step 3. Now step 4, the managing the uterosacral ligaments. The properly dissected the uterosacral ligament and cardinal ligament is caught with the cocker clamps. Usually, the space is slice during the vaginal study. It is sufficient to apply the one cocker clamp for ligating the uterosacral ligament, and that is you clamp the single with the single clamp and cut it with scissor. we have to apply the coccus clamp with flush to the cervix butt and cut and ligate it with the Vicryl number 1 or 10. And many times that these uterosacral ligament I suspend on the posterior vaginal wall. I attach that the uterosacral ligament that's Vicryl to the posterior vaginal wall for the anchoring, that is to prevent the future wall prolapse. That's step number 5, managing the uterine artery. Proper skeletonization of the uterine vessel. Uterine vessels are not cut after the clamping, but going to the closure of the uterus, which shaved off from the minimal uterine tissue. Thus, even if we release the clamp, the uterine vessels will not bleed since the vessels are not cut. Because the anatomy of the uterine vessel, it comes laterally at the internal os level and go upward. One branch, descending cervical branch, go below. That is the main part. We apply the coccus clamp at that level of that internal os, flush to the cervical region to avoid the ureters, and we shaved off that uterine tissue. We do not cut that uterine vessel. That's why it just separated from the cervical, that uterocervical region, and clamp it. That's why if mistakenly that clamp is just released also, get released also, there will be no bleeding because it is not cut. It is just separated from the uterine wall. That's why we clamp it and cut it with just separate with scissor with the part of the uterus, some part of the uterus, and ligate with the Vicryl number 1. Then again, the step 6, the managing the ascending branch and uterine artery, ascending branch of the uterine artery. That's already I have told you that. And step 7, the management of the last pedicle. That is the round ligament, tube, and tubo-ovarian ligament, and vessels. Single coccus clamp is applied over this pedicle. Always use the single coccus clamp. No need of using 2 double clamps for any pedicle. Because if you use a proper clamp and clamp it, then there will be no need of using 2 clamps. Always ligate the round ligament separately, far from the uterus. That is very useful if you go for the salpingo-oophorectomy. If you cut the round ligament first, then we'll go the directly infundibulopelvic ligament, and we can clamp it with the coccus clamp, and we can do the salpingo-oophorectomy also in that cases. So for that, you must practice of ligating round ligament first, and then go for the if you don't want that uterine ligament, not you want to, then you just clamp it. If you don't want to take out salpings and ovary, then go directly to the utero-ovarian ligament and clamp it. Step number 8, managing the vaginal wall. One stitch is made at the lateral angle of wall from the anterior or posterior vaginal wall and tied with the uterosacral ligament to give extra support to the wall. In patient with advanced degree of prolapse, additional procedure like sacrospinous ligament fixation may be required. If that is also important, because after finishing the vaginal hysterectomy, the future, that is the wall prolapse, precaution for the wall prolapse is very essential. Basically, we anchor the bilateral uterosacral ligament clamp, means that clamp, that I suture that clamp with the vaginal wall, that it anchored to that vaginal wall. Then it prevent the future vaginal wall prolapse. Many times, many surgeons can may do that sacrospinous ligament fixation also. That is very, but it's very difficult to do that also. Personally, I don't do that. I just anchor the this one means uterosacral ligament suture to the vault means vaginal wall that that prevent the future vaginal wall prolapse. Vaginal hysterectomy in prolapse, that is also in many cases we do the vaginal hysterectomy in genital prolapse. The principle that the only definitive cure for prolapse is surgery. Surgery has in providing the relief against the symptoms of prolapse by restoring the pelvic anatomy, sexual functioning, and the human physiological function, micturition, defecations. The principles of surgery of POP, pelvic organ prolapse. The primary site of the damage should be identified first and over repaired in order to reduce the chance of the recurrence. That is very important. All these things about the pelvic organ prolapse. These are the supports we already seen the levator and the active supports and passive supports. You already that seen also. That is the only repetitions. The level 1 support, you also know the uterosacral cardinal and this level 2 supports, level 3 levator and muscles. That is, this slide is very important. The upper side of the upper this one vagina structure involves the ligament and uterosacral types of defects. That is the prolapse of uterovaginal intraocular vaginal wall. Site of middle vagina is the second level. If there is a fascia of arcus tendinous, then pubocervical defect is the paravaginal pararectal. Lower in this one cystocele and rectocele. This is the 𝙤𝙤𝙢𝙚 defect. 𝙤𝙤𝙢𝙚 is this one. Is the scientist's name that he's described the level 1 support and types of the defect, the 𝙤𝙤𝙢𝙚 defects. Muscles are pelvic. This one the pelvic floor muscles. This is the levator and mostly the this one and the urogenitals diaphragm, superficial muscles of pelvic floor. That is very important in repair in doing the repair surgery of cystocele and rectocele. Risk factors of prolapse, the postmenopausal women due to the reduced estrogen levels, injury during the parturition, means childbirth, and multiparous woman because of this slag and atomicity because of this one support and this multiparous. In these cases, the prolapse occurs. This is the grading of the prolapse that shows system, anterior wall and the posterior wall, uterine prolapse. This is the grade 1, grade 2, grade 3. This is the grading of the how we'll differentiate the system. This is 𝙤𝙤𝙢𝙚 also stage 1, stage 2, stage 3, stage 4, and stage 4. It's a grading also. There is 𝙤𝙤𝙢𝙚 level of prolapse. This is a POP, means this quantification of the prolapse organ, POPQ systems, quantification of pelvic organ prolapse. And this is very, it's a quantification of the pelvic. It should do all these things are very important when you operate on the pelvic organ prolapse patient to give the maximum benefit to the patient. How is these are the points, 6 points as very important for quantification. And it gives the total genital hiatus and perineal body. These are the points, interpretations and measurements of this one. Also, it may take the whole lecture on this POP quantification. This because you must do before going to repair or in such a prolapse patient. all these quantifications and before surgery and after surgery, you must write down on paper on these quantifications. This these are the stages of the POP system according to the maximum prolapse and following the stages of POP classification. Choice of the surgery, degree of prolapse, and all these things you have to consider before going to the which type of surgery you should do in such cases. Many times we do the anterior vaginal hysterectomy with anterior and posterior repair. Anterior repair means anterior colporrhaphy. That is the most commonly performed surgery to repair the cystoscopy and rectoscopy. Vaginal wall is reflected on either side to expose the bladder and vaginal fascia. Bladder is pushed upward and vaginal skin is separated from the underlying fascia. To overline the vaginal pubo-cervical fascia, plicated with the chromic catgut and the corrected vaginal wall laxicity and close the hiatus through which the bladder herniates, and redundant portion of the vaginal mucosa is cut on either side. That is the anterior repair. We'll do the posterior repair also, posterior colporrhaphy, and with that colpoperineuralgia also. While repairing the rectocele, most surgeons perform the posterior colporrhaphy. This process involves a non-specific midline plication of the rectovaginal fascia and lack of the vaginal tissue over the rectocele excised, and medial fibers of the levator ani are then pulled together, approximated, and sutured over the top of the rectum. After every vaginal hysterectomy, cholecystoplasty should be performed. That is the McCall cholecystoplasty that I already described you, that we take the uterosacral ligament through the suture of the vaginal wall. That is McCall cholecystoplasty. Some surgeons do the vaginal sacrospinous fixation. That is the vaginal wall is fixed to the sacrospinous ligament from the ischial to 1.5 to 2 centimeters medial to the ischial spine. After some years of vaginal hysterectomy, there is a lots of evolution. The nowadays will just like a minimal invasive surgery, that is the laparoscope. Nowadays will the minimal invasive vaginal hysterectomy also. MIVH. That is, it's an addition to the vaginal hysterectomy. That the vaginal hysterectomy can be done with three types. With clamps, ligation of the pedicle with the vicryl or catgut, that one, vicryl, mainly vicryl. That is the single one. Second one, the clampless, the vaginal hysterectomy with the ligation of the pedicle. And third one is the vaginal hysterectomy with the use of energy source. That is the minimal invasive. The electrosurgical unit it's used in this vaginal surgery. I mean, vaginal hysterectomy. Previously, there used to be monopolar instruments. Now we use the bipolar instruments. There are very much improvement in the bipolar instrumentation. It has vessel scale scaling capacity, bipolar cutting ability, tissue impending feedback on the computerized cartridge also. Advantages of the use energy sources. Bipolar coagulation is the simplest, easily available. It's the same now. Many of using high-end pottery machines. It has a bipolar coagulation facility and vessel sealing facility also. Vessel sealing that way. That can be used in vaginal hysterectomy also. It's a safe, even useful for open surgery also. And it's cost-effective, beneficial in doing NDVH, non-descended vaginal hysterectomy procedure. Post-operative pain is very less because we don't use the vicryl and all that thing. That's why there is no ischemia. That's why there is no pain after surgery. Bipolar clamp is reusable. So this is the advancement in the 10 steps of the hysterectomy. All the many steps are the same. Keep the cautery ready on hold the cervix. Keep the cautery settings between the 40 to 45 watts. That the bipolar cautery. Now our aim should be the make the area white, not black. Open the POD, that same in the I have explained that one. The open the POD and posterior pouch also, and push the bladder upward instead of clamp ligature. Hold the pedicle with biclamp. I will show that that biclamp also. And cauterize it till it becomes white and bubble stop coming out. Always stay near to the uterus. Start cauterization and cut the pedicle with the scissor. See the hemostasis if any ooze cauterize. Step by step move upward by cauterizing and cutting the pedicle. Even the uterine pedicle can be cauterized before opening the peritoneal passage. I would told you that don't rush to the open the entire pouch. Just dissect the bladder and leave it and open the posterior pouch and go upward to ligate the uterine gland. At the last pedicle of the ovarian and coronal system, don't give extra traction. That's one important because if it gets slipped out, then there will be the hemorrhage from that because the supply is from the direct aorta, ovarian artery. Remove the uterus and do the vaginal suturing as usual. That is the 10th step of uh, mini invasive. That is a bipolar biclamp hysterectomy. That is also called the biclamp hysterectomy. This you can use this NDVH procedure, NDVH type of surgery. This one in uterine fibroids also. Patients' desires and important indications are already described: the menorrhagia, severe dysmenorrhea, urinary retention due to the big fibroid, symptomatic fibroids with size above 12 weeks. That is the indication for hysterectomy in uterine fibroids. You can do 12 weeks uterus hysterectomy through through vaginas. Criteria for deciding the approach: exact the location of the fibroid. That is very important. That is whether anteriorly, posterior, or frontal. That we have to see first. Detailed sonography reports mandatory. Laxity, rigidity, availability of the uterus free space, access to the large fibroid, added factors like CS and adnexal pathology that you have to first see. Please, willingness of the patients also very important. And lastly, the experience of the surgeon. That is if the angle between the cervix and uterus, uterine body of the uterus is less than 90, then there will be the very difficulty to do vaginal hysterectomy in uterine fibroid. If the angle between uterine body and cervix is above 140 degree, then means you have to just see that one. If there is an angle, it's acute angle, then there must be the difficulty doing the vaginally. Assessment of the fibroid is very important. That you can remove all these fibroids by debulking, morcellation, bisection, and intrabiometric coring. Debulking should be begin only after the ligation of the bilateral uterine artery. That is very important. After ligating the uterine artery, then you go for the debulking, morcellation. These are the procedures to deliver the uterine fibroids. You must go first remove the posterior wall fibroid, then anterior wall, and lastly the fundal. These are the some cases that I have done vaginally. This in my hospitals. These are the instruments that's very useful in doing vaginal hysterectomy. The myoma screw and capscot, the instrument that is very important to catch the myoma and to deliver it from the myometrium. In the many cases, we have to do the salpingo-oophorectomy also. Before going that one, you must see this one, the indication, postmenopausal in cases, you must do the salpingo-oophorectomy. And if a patient having the family history of one or two or more affected relatives with ORM malignancy, then we do the prophylactically salpingo-oophorectomy in vaginal hysterectomy cases. The prerequisites for normal tubes and this ovaries should be there, easily accessible. The ovaries and tube fallopian tube should be easily accessible. Free mobility of the ovaries should be there. And the one technique is there that is called the Zimmerman technique of the oophorectomy. That is the first one. We clamp the round ligament from the uterus and then go to the infundibulum pelvic ligament. That is the specially designed the clamp for applying the over the infundibulum pelvic ligament. That is this clamp is developed by the Dr. Shades, and it's very useful to when you do the salpingo-oophorectomy by clamping the infundibulum pelvic ligament. Use of energy source in VH. The types of energy source, monopolar and energy-based vessel sealing, that's the bipolar energy source, ultrasonic. We use the bipolar energy source, the seal safe. It is specially polar colored, used for contact coagulation basis for tasks such as fusing tissue layer, sealing the blood vessels, and denaturing the tissue layer prior to the dissection so as to avoid the hemorrhage. Vessel sealing system, that is another modality to do the vaginal hysterectomy. This is the bipolar clamp that use doing the bipolar vaginal hysterectomy. These are some instruments that I use during the vaginal hysterectomy. It's very easily. There's a long sim speculum, long blade sim speculum is very useful in doing the vaginal hysterectomy. And I use trinaculum to hold the cervix during the hysterectomy also, and cat's paw, that's for myomectomy during vaginal hysterectomy. Thank you very much for hearing patiently. Thank you very much.
Excellent talk, sir. And beautifully you have demonstrated step by step for vaginal hysterectomy, especially the anatomical part, anatomical aspects, and the steps that you have demonstrated basically. So these are very useful, and practically we means apply this on during the vaginal hysterectomy. So
Yeah.
I think this webinar is with all combi pack for a vaginal hysterectomy, and all delegates must have.
It is better to see and explain,
Yes,
definitely.
yes, yes.
But
So
the
I
many
will
tips.
request you, sir, if you can, if it is possible, can you record one vaginal hysterectomy step by step with holding,
Yeah,
even
yeah,
with each and every explanation regarding holding the needle, passing the needle,
Ah,
and
yes, yes.
how
The
we should do that.
position
It
of
will
the
be more.
needles
Yes.
is so important doing the
Yeah.
during the ligation of the pedicle.
Yes. 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 So I think if you put any your recorded video, that will be very much useful for all of us. So it will my personal request for you.
Yes, yes, yes. I will do that definitely.
Yes, yes.
Yes, I will just do that recording and put on our this WhatsApp group. Definitely.
Definitely.
Good evening,
And
sir.
Yes. Good evening. Good evening.
Lecture was very nice, sir. You have described each and every step so precisely, so nicely.
Yes,
Really, it gives lot of inputs in our day-to-day practice. Thank you, sir. I have one query.
Okay, yes,
Uh,
go ahead.
you have described MIVH.
Yes,
Then how
MIVH.
then how to suspend a bolt with uterosacral with that surgery?
No, same. We are not using the ligature, that's a vicryl. We are not using the ligatures only.
Like,
We
what
are
about
using the
what
biclamp.
I'm asking about what suspension?
Yes, na. Whole suspension will go that will take the suture again.
Okay,
Will
okay.
during yeah, we are closing the vault, no? Definitely.
Yeah.
We are closing the vault with the vicryl. During closing the vault, we'll take the uterosacral along with that. Got it?
Yes,
Yes.
sir. Yes, sir. Yes, got it.
Take
Sir,
the
generally what
uterosacral
we
along
do,
with.
actually, we do not cut the means uterus that means vault जो है हम लोग just 2 to 4 o'clock और 4 से 8 o'clock में ही कट करते हैं, ताकि हमको फिर से वॉल्ट के लिए सस्पेंशन करने की ज्यादा जरूरत नहीं पड़ती है. तो that is
Many of us
also.
can. Yes. Yes. Go ahead. Hello.
हाँ सर, हाँ नहीं, आई एम जस्ट एक्सप्लेनिंग इफ यू वांट टू अवॉइड दैट कि सस्पेंड करना है और एनीथिंग इवन फॉर प्लेन वजाइनल हिस्टेक्टोमी आई एम टॉकिंग अबाउट.
Yes.
So specially what we used to do that we never take the incision all through the cervix. We just go from from 10 to 4 o'clock or 2 o'clock, and we will again for 4 to 8 o'clock.
Continue posteriorly only.
Yes.
Priyanka.
Do
Yes.
not cut the
Priyanka,
laterally. We do not
we
cut
can-
laterally.
No.
we can do whatever. Priyanka,
आवाज ब्रेक हो रही है सर आपकी.
whatever you have explained that we can do in NDVH cases, not in the
Yes.
patients of prolapse.
No.
In the
No.
patients
I'm
of
talking.
prolapse, we
Yes,
have
that's
to
what I
dissect
explained.
the.
I'm talking only about the NDVH, means plain NDVH.
Okay.
No, I take
Accepted.
benefit. I take routinely the circumference incision.
Yeah. Okay.
Take lateral, anterior, posterior, lateral, circumferential incision. I take routinely. And during bipolar, using bipolar, I just cauterize that point. And during the this wall suturing, I take the uterosacral along with that.
Yes. And even in the prolapse also, we used to maintain same procedure. Means
Yes.
we do not means don't need to cut it off from all the sides. Yes, we can go with 10 to 2 o'clock. Yes. Not necessary that you should cut in the prolapse with the circular incision.
No, not necessary.
Yes.
It's a way of practicing. Yes.
Yeah.
But that is called as a McCall procedure. That can be used in that case.
The only thing that is the difficult part when in the prolapse is that we need a proper suspension, because it's not just कि हम मतलब उसको ले रहे, either you have to take a high uterosacral suspensions or you have to take to the sacrospinous suspension. That is little bit difficult to dissect till the sacrospinous.
Sacrospinous. That is very, very good. Yes.
Yeah.
That
because the main holding structure of the uterus is the uterosacral. And if and the prolapse is basically that the means the main structure of uterosacral, that is sagging, means that's what the prolapse mostly happened.
Yes. Because of that
and
bailing down and all these things before full dilatation, that labor due to the labor, it happens. Yes. The
and if we are doing just only means ligating it with the pedicle of the uterosacral, then it's not going to work, because we are again means taking with that weak ligament who has already been sagging, means reason for the sagging of the uterus. So at that time we need a perfect suspension for that purpose.
Yeah. Yes. Yes. For prolapse only. No? Yes.
Any questions? Prajakta?
Thank you so much.
Yeah.
Yeah,
Aarti, continue.
Ma'am,
there are currently no questions in the chat box. I will encourage all participants to put their queries in the chat box. And now
Yeah.
I would like to hand it over to Dr. Aarti for the Q&A session.
thank you so much, sir, for this wonderful session. So now we will start with question and answer series. We have one question, sir. What precautions or what steps should be taken pre-operatively in case of prolapse with detrusal underactivity?
In case of prolapse,
With detrusal underactivity.
uterus under
Activity. Detrusal muscle underactivity. DU.
The question is not, we are not getting what exactly
getting
want
that
to ask.
one.
Yeah, ma'am. Like such is the question put in by Smita.
Can you
Prolapse.
read it again?
Yeah, I got it. So what precautions or what steps should be taken pre-operatively in case of prolapse with decubitus ulcer?
Okay, decubitus ulcer. Okay.
Yeah.
Oh, okay. Decubitus ulcer.
Yeah.
Yes, I definitely for some days before the surgery, we apply the betadine pack. We do the betadine pack for 7 to 8 days. In Tarachan Hospital, we use that runner open tail also for that. And before that one, we take the biopsy and pap smear definitely to rule out the CA. And after that, we apply the that runner open tail picho for 7 to 8 days. It will get the heal, and then after we'll do the hysterectomy with repair.
Thank you, sir. So we have one more question like conditions for infiltration of tranexam and adrenaline. Where we have to do that condition you have to explain.
No, if there moderate means procedentia with if the case is of procedentia and there will be the definitely some oozing from the pouches and during the incision on the vaginal wall. That time we have to use that adrenaline, just 2-3 drops in a 40-50 ml of normal saline. That is sufficient to for vasoconstriction and minimize the hemorrhage. So we can use that adrenaline in that cases. It's prolonged prolapse cases also. But I don't use vasopressin. I have not used till now in such a cases. But only adrenaline and normal saline infiltration is sufficient for such cases.
Thank you, sir. We have one more question. This cause of PV spotting and bleeding after post-op vaginal hysterectomy.
Many times it's because of we suture the vault. Maybe because of that wall, from wall there may be the spotting for 7-8 days on and off. But if there is a secondary infection at the vaginal wall, then there will be the secondary hemorrhage that we have to rule out first and treat accordingly to that. Primary hemorrhage within 24 hours due to the slippage of the ligature. But secondary hemorrhage after 48 hours and onwards, that may be due to the infected vaginal wall.
Thank you so much, sir. Again, we have one more question. So, what will be the complication if we remove the Foley's catheter on second day after vaginal hysterectomy?
Yes, if you are not done the repair and anterior posterior repair, then you can remove the Foley's catheter after 12 hours also. There is no need to keep Foley's catheter after that. If you have done the prolapse, anterior posterior repair, bladder cystocele, cystocele repair, then you have to keep the Foley's catheter for 3 days.
Okay. Okay, thank you,
But
sir.
in previous LSCs, do you prefer to go from lateral to center, or you generally follows the same?
Generally, I go lateral window technique, Dr. Shades technique, and otherwise I do one another method. I take the 20 cc NS and infiltrate at the base of the bladder. That where the attachment is there.
In the bladder pillars, you mean to say?
हाँ, bladder pillar. और वहां से मैं सीजर से will take the blunt cut through the that's uterine wall, cervical wall, and just remove it, chop it out.
Okay. With the finger dissection, you mean to say?
Yes.
And that's nice. Yeah.
Otherwise, I go through lateral window technique.
Okay.
Just like you do in laparoscopy patients, TLH cases.
Nice.
In TLH
Nice
with previous. Sorry.
Yeah, today it's a good, miss. We are having the good interactions of regarding the vaginal hysterectomy. I think even we can continue this again for 24 hours in the group.
Yes, definitely.
I would like to, yeah, and with the video demonstration, especially.
Yes, the video demonstration is very important. Definitely.
Yes.
Then that may be the very useful for all viewers. And vaginal hysterectomy is my
Special attachment you have.
yes, definitely. I have all the instruments. I will keep all the instrument to my near to on table to show you all these things. And that last slide I have shown this one. All
yeah,
the
nice.
So we have another question. How can you approach or manage bladder injury, and what are the chances of bladder injury and its management?
If there is a history of previous pelvic surgery, that means the cesarean section, myomectomy, and in that case there may be the possibility of bladder injury. Definitely, in that cases you just see where is the rent is there, and if there is a doubt of in bladder this rupture, then I push the 100 to 200 ml NS with methylene blue through Foley's and see that there is any leakage through any rent. If there is a rent, then we catch it with artery forceps anterior posteriorly and suture it with 20 catgut or 30 vicryl continuous locking in 2 layers. And keep the Foley's catheter for minimum 8 days.
Now we have ended with this question and answer series. So thank you so much, sir, for this wonderful session. So now on behalf of NIMA OBGY Society Central and NIMA OBGY Society Maharashtra body, I would like to express my gratitude to NIMA Central, Dr. Ashutosh sir, Dr. 𝑢𝑠 sir, for the remarkable support. I extend my gratitude to our NIMA OBGY Central President, Dr. Kamini Dhiman Madam, Dr. Priyanka Nakade Madam, Dr. Vishnu Bhavne sir, and Dr. Rajesh Uttani sir. I would also like to thank and extend my gratitude to eminent speaker, Dr. Pradeep Musale sir, who took his time from his busy schedule and delivered this lecture. I would also further extend my Thanks to gratitude to NIMA OBGY Maharashtra, Dr. Suhas sir, Dr. Manoj Gaikwad sir, and Ajay Raj sir for their support and conduct today's webinar. I would also like to thank Dr. Girish Daga sir for the help and technical support. Last but not the least, I would like to thank from bottom of my heart all the delegates and the participants for the presence. Without them, this webinar would not be so successful. Now, with due permission of all the dignitaries, I'm concluding this today's webinar. Thank you for attending and hope you have learned and gained knowledge from today's speaker. So thank you. Thank you so much.
Oh, thank you very much. Oh,
Thank you, sir. Thank you so much.
thank you. Thank you.
Thank you, sir.